Hello, Holistic. Today's topic is dehydration and rehydration in the palliative care setting. These are the objectives we'll be going through today. We'll start with some physiology here. Total body water accounts for approximately 60% of the total body weight. This could be 70% in a newborn or maybe 50 to 50% in a mature woman. Components of body water: intracellular and extracellular. Intracellular is around 63%, and the extracellular is 37%. And then here you can see the interstitial fluid, the plasma, lymph, and transcellular fluid. Another physiology slide here showing the different ion concentrations, extracellular and intracellular. As you can see, the potassium is basically intracellular, while the sodium is mainly extracellular. And this slide shows the movement of fluid. It's a dynamic state between extracellular and intracellular fluid. Also here you can see the total intake of water per day and the average daily output of water. The total intake is related to what you drink and what you eat, and also the metabolism in your body. While the output could be through the skin and lungs, could be through the sweat, and it could be through the urine. Again, this is a picture for a patient that's have his cell well hydrated here, and this one is, if excess extracellular fluids are lost, the cells themselves, they get dehydrated. Research in rehydration and dehydration, uh, especially in eminently dying patients, is kind of limited. The best available evidence that suggests that hydration of advanced cancer patients plays an important role in maintaining cognitive function and is therefore an important factor in the prevention and reversal of delirium in this population. Terminal dehydration is a highly controversial topic, and there are so many factors, as you will see, through the lecture here, that affects the decision making. So what is dehydration? Before I explain dehydration, I have to explain fluid deficit. Fluid deficit is the state of water loss, with or without electrolytes, which includes the subtypes of volume depletion and dehydration. Dehydration should be understood as total body water deficit that's predominantly intracellular and associated with hypernatremia. Volume depletion implies deficit in the intravascular fluid volume and could be isotonic, hyponatremic, or hypernatremic. Fluid deficit is either volume depletion or dehydration. Dehydration is intracellular, volume depletion is intravascular, dehydration is hypernatremic, volume depletion could be hypo, isotonic, or hypernatremic. Comparison between fluid loss and fluid deficit. We see fluid loss in situations like diarrhea, diuretics, patients who are diabetic, uh, as well, fistulas, sweating, hypercalcemia, bowel resection, and vomiting. Physical assessment. The classic signs of fluid deficit include dry mouth, reduced skin, turgor, postural hypotension, tachycardia, reduced jugular venous pressure, sunken eyes, and reduced sweating. Symptoms of the fluid deficit can also include behavioral, cognitive, and cognitive changes and fatigue. Again, classification of fluid deficit according to the total body weight loss, according to the osmolality, and according to the blood level sodium. So severe cases of fluid deficit is characterized by a weight loss of more than 10%. Moderate is 5 to 10, and mild is less than 5%. Dehydration symptoms: thirst, dry mouth, rapid heartbeat, concentrated urine, dry skin, and headache. Laboratory evaluation: common finding in elevated levels of urea, creatinine, plasma protein, hematocrit, and sodium. So, what are the arguments against and the arguments for parenteral hydration? Arguments against parenteral hydration: there is less urine and thus less problem with incontinence and catheter use. Decreased gastrointestinal fluid associated with dehydration results in less nausea and vomiting. Decreased respiratory secretions will result in less cough and pulmonary edema. The severity of edema and ascites is decreased. Parenteral hydration is uncomfortable and limits patient mobility. Arguments for parenteral hydration: parenteral hydration assists in making dying patients more comfortable. There is no evidence that parenteral hydration prolongs life. Fluid deficit can cause restlessness, confusion, and neuromuscular irritability. Oral hydration is provided to dying patients complaining of thirst, and therefore parenteral hydration should be an option. Withholding parenteral fluid from palliative care population may result in withholding therapies to other compromised patients. So what is the bottom line here? At end of life, shall you hydrate or don't hydrate? Well, it depends. If you're having cognitive changes, delirium, at end of life, replacing fluids will be beneficial. Otherwise, it could be a burden by increasing the total body water in your system and overloading the cardiovascular system and also increasing secretions in your lungs. But if you have a delirium, it would be helpful to give a bolus of fluids to these folks to flush all the toxins and metabolites of drugs from their circulation. So, one nice study done in Canada, they looked at the routine practice in palliative care. And basically, they found that physicians estimated the ordered or parenteral hydration is around 6 to 10% of patients. The routes for parenteral hydration were intravenous, around 30%, and hypodermoclysis, around 30%, 70%. So, in fact, uh, experienced palliative care physicians do not usually order parenteral hydration, except for 10% of these physicians. 30% they use the regular IV route, and 70% they use the hypodermoclysis. And the estimated average volumes range from 200 to 2400 ml. Again, effects of hydration near the end of life, the pros and cons. Again, the most important thing to learn is um, fluids at end of life could be detrimental, except in patients with delirium or cognitive changes. As you can see here, increased pulmonary secretions, causing more dyspnea, cough, and congestion, edema, uh, increased GI fluid output with increased risk of nausea and vomiting, increased urine output with increased need for urinary catheters, and increased infection risk. Okay, oral versus non-oral hydration. I have to make this very clear to all of you guys. Oral hydration, there is no controversy about it. If you're able to give the patient oral hydration, okay, and I'm very clear about it, that's completely okay. Okay, this is a way to comfort your patient. What we are debating is the parenteral hydration. Okay, as I told you before. Delirium. Since we talked about it, these are the different factors, involved in delirium. Causes of terminal delirium or agitation. One of them is opioid toxicity, pain, drug interactions, sepsis, hypercalcemia, raised intracranial pressure, urinary retention, and organ failure. Hydration research. The hydration research looked into three aspects. Number one is the biochemical findings and hydration status. Number two, the biochemical findings and the clinical symptoms. Number three is the association between hydration status and the clinical symptoms. So, as far as the biochemical findings and hydration status, there is no controversy that dehydration is the cause of renal failure. However, while parenteral hydration is accepted standard management in many settings, the impact of fluid deficit and rehydration on the renal function and electrolyte balance of palliative care population is still questioned. And I'm quoting here, a couple of articles talking about this. So, in other words, the biochemical effects in a non-terminal patient could be a huge problem, and thus you need to give parenteral fluids. But at the end of life, the story flips, and in fact, fluid overload will be the case in these scenarios. Okay, biochemical findings and clinical symptoms. So, I quoted two articles here, which basically concluded that delirium is multifactorial. Hydration using hypodermoclysis may be one of the potential useful measures to consider. This one shows you the opioid metabolites for morphine and hydromorphone. And morphine is metabolized to M3G and MXG through glucuronidation process. If you have impaired renal function, these metabolites can actually accumulate and can cause neurotoxicity. Hydration and clinical symptoms. So again, I quoted a very nice article for Dr. Barrera, where he randomized patients, at end of life to two groups. The ones that had the fluids or bolus fluids, they improved in their sedation and myoclonus scores compared to the one that did not receive the hydration, which will get us again to the same, concepts that I was trying to tell you. Uh, Unfortunately, these extra amount of fluids, they increase the respiratory tract secretions, as you know. Okay, so again, these are studies with hydration and clinical symptoms. Uh, the hydration of 1 liter per day did not show that it improved symptoms, quality of life, or survival. However, it does help with delirium and cognitive changes. But we've seen also that higher volumes at end of life, uh, can lead to more documentation of dyspnea. There are ethical, social, and cultural key issues when determining the role of non-oral hydration. Um, let's revise some important concepts. Critical care means mechanical ventilation, vasopressor, artificial nitration, hydration. Prerequisites of ANH is a medical indication, definition of therapeutic goal, and the will of the patient. Comfort care means supplemental oxygen for comfort, symptom management, and pleasure finding. Withdrawal of life support is equivalent to withholding of life support. So just this is like a quick introduction, so we can understand the basic ethical principles in medicine in general, which is basically four things: autonomy, beneficence, non-maleficence, and justice. So, what are the key issues when determining the role of non-oral hydration? Uh, First, the patient divine goals, okay, or the surrogate, of course, if the patient is not able to communicate. The symptom burden, as we said, the only thing that could be helpful at end of life is improving delirium. Burden to the patient caregivers of maintaining the non-oral route of hydration, family distress concerning withholding hydration and nutrition. When in doubt, always do a time-limited hydration, which is an appropriate recommendation. So sometimes there's you get into a debate with the patient family regarding the hydration at end of life, and it becomes very complicated discussions. There is no problem to give some fluids, but very calculated amounts, and see whether this will help the patient or not. In the United States, they have an important document called the Pulse, or Physician Orders for Life-Sustaining Treatment. Okay, and this is composed of four items. Item A is the cardiopulmonary resuscitation. B is the medical interventions. C is the artificial administered nutrition, and then D is the information and signatures. So, here in section B, they talk about IV fluids and whether the patient would like to receive IV fluids at end of life or not. Islamic views on artificial nutrition and hydration in terminally ill patients. Withholding and withdrawal of artificial nutrition and hydration from terminally ill patients poses many ethical challenges. The literature provides little information about the Islamic beliefs, attitudes, and laws related to these challenges. Um, there's also a harm that terminally ill patients, because of the complications such as aspiration, pneumonia, dyspnea, nausea, and diarrhea, and hypervolemia. From the perspective of Islam, rules governing the care of terminally ill patients are derived from the principle that injury and harm should be prevented or avoided. Basically, beneficence and non-maleficence. Islamic views on artificial ventilation, and such as hastening of death by withdrawal of food and drink is forbidden. But Islamic law permits the withdrawal of futile death-delaying treatment, including life support. Nutritional support is considered a basic care and not a medical treatment, and there is an obligation to provide nutrition and hydration for a dying person, unless it might shorten his life, causes more harm than benefit, or is contrary to an advanced directive that is consistent with Islamic law. So, in short, Islamic laws really goes along with the basic, ethical principles that we just talked about: the autonomy, the justice, non-maleficence, and beneficence. So, what is oral rehydration? As we said, we have no controversy whatsoever about oral rehydration therapy. Okay, actually, we should give it to all patients, whether they're terminal or non-terminal. I'm trying to make this very clear to all of you guys. An oral rehydration solution, uh, like the one that we use for diarrhea and stuff like that, is composed of sodium chloride, potassium chloride, and glucose. And then you dissolve it in water and you drink it. This way, you replace both the water and the electrolytes needed. Non-oral rehydration therapies include nasogastric tube, PEG tube, proctoclysis, intravenous hydration, and hypodermoclysis. The most famous are the intravenous and the hypodermoclysis. Nasogastric tube, gastrostomy tube, or what we call PEG tube. PEG tube comes with its complications, such as aspiration pneumonia, bleeding, infectious peritonitis. It can lead to necrotizing fasciitis, gastroclonic fistula, perforation, and death. These complications comprise around 1 to 2%, while minor complications are somewhere between 7 to 2%, 7 to 10%. So, what are the difference between a PEG and nasogastric tube? Nasogastric tube is mainly used for short term, while the PEG tube is for long term. And mainly, the PEG tube is used for conditions which impair swallowing. Okay? Another method that is used is called the proctoclysis, invented by Dr. John Murphy. Proctoclysis is a slow, continuous administration of saline solution instillation into the rectum and the sigmoid colon. The nice thing about this method is so cheap, and it could be done anywhere, at home, and anywhere. It's very simple to administer, and this could, basically replenish the patient needs from fluids. This is how it looks like. It's very simple apparatus. So this could be a very useful technique in underserved areas. Hypodermoclysis. This is a very important topic, and there's a lot of interest in it all over the world. Okay, we call it clysis for short. Basically, is administration of fluids to the hypodermis or in the subcutaneous area. Preferred solution is just the routine regular sodium 0.9% sodium chloride, what we call normal saline. You use a butterfly, preferably, a large gauge, so doesn't get clogged. Very simple to administer, and there are certain areas where you can place this butterfly. This is anteriorly, this is posteriorly, and I usually like to put it here, or in the belly or in the arms. Very cheap method. You can attach the saline to it with a regular IV setup. This technique was developed by Rudolf Matus. Okay, nowadays it's gaining a lot of popularity because of its simplicity. It could be used at home, it could be used in the hospice, could be used in any setting, even in patients that you're not able to find any IV access for them. Usually, you start slowly and then you increase the rate. As long as there is no redness around the butterfly and there's smooth flow, you can go up to 100 to 120 ml per hour. In old days, we used to use an enzyme called hyaluronidase enzyme. And this basically, it actually accelerates the speed of the flow by eating this connective tissue in the subcut area. They actually found that, you can still do the hypodermoclysis without hyaluronidase. At a certain point, it was pretty expensive to buy this enzyme. Now, it's genetically made. So if you feel like you're having difficulty, you can add 150 units to the liter of hyaluronidase. This will facilitate, the flow of the fluids. Very rarely you get allergic reactions from hyaluronidase enzyme. Again, this is the hyaluronidase, and this is how it eats this, connective tissue fibers here, and basically makes the flow more smooth. Advantages of hypodermoclysis: the low cost, it's more comfortable than IV administration. less likely than IV administration to cause pulmonary edema or fluid overload, simple insertion, less distressing than IV, easier insertion at new site, more suitable for home care than IV line, with less staff supervision and less need for hospitalization, can be set up and administered by nurses in any almost any setting. Doesn't cause thrombophlebitis, has not been shown to cause any septicemia or systemic infection, can be started and stopped at any time by opening and closing the clamp on the clysis tubing. No danger of clot formation. Disadvantages of hypodermoclysis: usually rate only 1 ml per minute, only 3 liters can be given in 24 hours. So it has a limitation as far as the volume that you administer to the patient, not like an IV. Limitations on administration of electrolytes, nutrition additives, and medications. Edema at the infusion site is common. Possibility of local reaction. Adverse effects of hypodermoclysis. Again, local edema, local catheter reactions, pain or discomfort, cellulitis, puncture of blood vessels, pulmonary edema, changes in plasma concentration of electrolytes, and then the side effects of hyaluronidase, which we said is pretty rare to happen, the allergic reactions. Okay, intravenous hydration, the gold standard. Basically, all of you guys are aware about how to use intravenous hydration. Um, this was actually using the IV for, you know, for fluid injections and medication injections was actually done by this gentleman here, Sir Christopher Wren. He was able to experiment on animals, and he used something like similar to a cannula that we have right now, a goose quill, and he injected different, agents inside. Okay, I want to wrap up this lecture for you guys. So I came up with these questions for you. I developed them because I felt that this topic could be really confusing to a lot of people. So before you attempt hydration, you have to ask yourself, is this patient dehydrated or not? Right? Number two, is this patient terminal or not terminal? Because it makes a huge difference. If it's terminal, then you'd be more skeptical about giving IV fluids because you can cause, fluid overload. While if the patient is non-terminal, you should give fluids. Otherwise, his renal function would be impaired. He will start to, accumulate different toxins. Okay. Is the patient able to take oral solutions or not? Is the third question. Because if he's able to take oral solution, you don't have any conflict to begin with. You should give him oral rehydration, whether the patient is terminal or not. What are the wishes of the patient or the proxy? So you need to understand, the patient's, uh, you know, uh, preferences at the end of life. If you're able to communicate with the patient or with his proxy. If the patient is non-terminal dehydrated, try oral or alternative. Okay. If the patient is delirious and terminal, try alternative route. So if I have a delirious patient, make no mistake, the fluids could, and the patient is terminal. That make no mistake that this patient is, can benefit from, getting a bolus of fluids here. All right. If the patient is dehydrated and terminal, balance the risk benefit ratio. See, this is what we're talking about. Being skeptical at end of life is important here. Okay, sometimes patients is delirious. You need to give him some fluids. Patient is not delirious. Probably, giving him too much fluids can cause, many complications to these patients. However, sometimes the family and the patient is pushing you to give some fluids. It's okay to give some, but be very cautious about the amount that you give to the patient. You can run the patient at very low rates and still satisfy the family and patient, desires to get fluids, and at the same time, don't get yourself into overloading the patient with excess fluid. Okay, so this is the last slide here, the key learning points. Hydration in palliative care is controversial topic with divergent opinions. Fluid deficits can cause confusion and renal failure. Hydration research is inclusive in guiding clinical care. Hypodermoclysis is an excellent alternative for rehydration in palliative care populations. Diverse clinical and sociocultural circumstances need to be considered. Evidence recommends that if terminally ill patients are not rehydrated, medication should be decreased to avoid accumulation and side effects. Rehydration may be helpful in some individual situations. Patient and family preferences need to be understood and incorporated in the treatment plan. Thank you so much.